Hello everyone, good evening. So, welcome to this recall session of medicine. So, first of all, just let me know in the comment section if my audio, video, everything is perfect. So, just let me know in the comment section. Yes. I hope I'm audible, so I'm just waiting for your comments. Okay, perfect. All right. So, let's begin the recall session. Okay. So, today we'll be discussing the medicine questions. So, before that, let me ask you first of all, how did you all do in the exam? I hope questions came from the areas that you studied and revised, and I hope that all of you would have done well. Now, today we'll be quickly going through the questions that were asked in the NEET PG 2021. It's a recall session. So, just let me tell you regarding the overall medicine that was asked in this exam, the overall question pattern. So, overall I think in medicine there was good weightage from the hematology part. Okay. Obviously, there will be some overlap with pathology. So, good weightage to the hematology part. You had good number of questions from infectious diseases. Okay. So, conventionally you would have expected more questions from the cardiovascular system, maybe more ECGs, but that was not to be. And along with that, let me tell you, many of the questions in the pharmacology part, that is clinical pharmacology you can call it, many of the questions were with respect to management part. Okay. So, you have got to have a good knowledge of your pharmacology as well as a clinical perspective to answer such questions. All right. So, that was the weightage. Yes, there were questions from neurology, endocrinology, good number of questions from rheumatology as well. Okay, rheumatology as well. And yes, you had questions from nutritional deficiencies. So, a mixed paper, I feel a balanced paper, because at least some of you were thinking that it could be a very long stem exam paper for most questions. There were long stem clinical questions, but I feel this was a balanced paper. But surprisingly, the question setters maintained a perfect social distancing from COVID-19 questions. So, there were no COVID-19 questions, direct questions from COVID-19, none was there for this exam. So, in contrast to the INI-CT where the weightage for topics like neurology were more, but here neurology CVS questions were asked, but again hematology was dominating, perhaps because of the pathology overlap as well. Okay. So, let's begin with the questions. Okay. The first question is this one. So, all right. So, this is regarding a patient who presented with bitemporal hemianopia. Okay. So, the clinical presentation of this patient is with bitemporal hemianopia, and an imaging finding is shown, that is an artery aneurysm is pressing on the optic chiasma. So, probably when an angio was done, okay, you could actually demonstrate aneurysm pressing on the optic chiasma, and they are asking what is the likely artery involved. Okay, what is the likely artery involved? Anterior cerebral, anterior communicating artery, middle cerebral artery, anterior choroidal artery. So, remember, even in my quick revision program sessions, I had said that nowadays, even from the basic subjects like anatomy, they often ask questions integrated with the clinical subjects. So this is one perfect example of such a question, because you have got to have a good idea of your anatomy, neuroanatomy as well, to answer this question. So I'd like to know from you guys what you attended for this question. Well, let's move on to the answer. The answer actually for this question is anterior communicating artery. So some of you wrote anterior communicating artery, some of you guessed it as anterior cerebral artery. Well, the most common vessel that could be involved here in this question is an anterior communicating artery, and I'll tell you why. Okay. Now you see here, when you have a ACOM aneurysm, anterior communicating artery aneurysm, so this aneurysm again can be very much closely related to the optic chiasma. So when you have an aneurysm involving your anterior communicating artery, the aneurysm actually can project into various directions, and you call them projections. Okay, what do you call them? You call them projections. So you have projections of the anterior communicating artery. So the projections can be inferior, which means the direction of growth of the aneurysm is inferior. Okay, in an inferior direction, it can be inferior. Okay, that is what is called an inferior projection of the ACOM. So you can have say a superior projection. Okay, a superior projection. Okay, a posterior projection, and even an anterior projection. So there are different projections. Okay, so this one will be the anterior and this is the superior one. So it's just based on the direction. Okay, so this one will be a downward and this one will be slightly anterior. This one, the projection will be posterior, and this one, the projection will be slightly superior. Now see, when you have a projection like this, you tell me out of these various projections, which projection is likely to have a optic chiasmal involvement, because the clinical presentation is that of a bitemporal hemianopia. So when you have a bitemporal hemianopia, you have got to have this aneurysm pressing on the optic chiasma. So the a more apt answer would be an inferior projection. Anyway, the examiner has just asked about the anterior communicating artery. So the ACOM aneurysm, especially the inferior projection, is likely to press on the chiasma and produce a bitemporal hemianopia. Okay, all right. So I'll just show you another figure also. Again, of the anterior communicating artery, you see you can have anterior projections, superior projections, posterior projections, then you can have the inferior projections. So when you have an inferior projection, it presses onto the optic chiasma, and you know from your ophthalmology that when you have a optic chiasmal involvement, you are likely to have a bitemporal hemianopia. So just see this question, how it is trying to correlate a clinical presentation of a bitemporal hemianopia with your neuroanatomy knowledge. Okay, so the answer is going to be a ACOM, anterior communicating artery. All right. So I hope everything is clear. Any doubts in this particular question? Shall we move forward? So this answer is going to be anterior communicating. Now if you may ask me, can anterior cerebral artery aneurysms produce optic chiasmal involvement? Well, very, very rarely. It can also produce, but it is very, very rarely, which is why I told you specifically in this question, the most common vessel that is likely to be involved is going to be anterior communicating artery. Okay, all right. So that is clear. Okay. Now coming to the next question. Okay, so the next question is regarding, again, a question from hematology this time. So this is regarding a 50-year-old male. So always remember, note the age of the patient. 50-year-old male presenting with complaints of fatigability for 1 year, and evaluation is showing mild anemia as well as massive splenomegaly. And coming to the blood investigations, hemoglobin 10, The total leukocyte count is there. It is 1,20,000 and the platelet count of 5 lakh. Neutrophil 60%, basophils, eosinophils is there, lymphocyte 15. Also seen where myeloblast, myelocyte, metamyelocytes and band. So you have an increased myeloid erythroid ratio, ME ratio, myeloid erythroid ratio. What is the most sensitive investigation? So let me tell you, whenever I discuss, the questions, I will be first of all giving you the answers for those students who have given the current exam. At the same time, I'll give you my suggestions for students, MBBS students who are watching this, because I know many of the students who are watching this are future aspirants as well. So I'll give you certain tips as well with respect to certain questions. Now for this, the most sensitive investigation is being asked. Okay. So first of all, based on the clinical presentation, that is an 50-year-old male, fatigability, you can see anemia and a massive splenomegaly, and the blood picture. Okay, the blood picture is clearly giving you an indication of what? You can see all sorts of cell lineages. Okay, you can see neutrophils, basophils, eosinophils, and also the myeloblast, the myelocytes and metamyelocytes. So it's an entire garden variety that is available as per the blood investigations, and increased myeloid erythroid ratio as well. So the clinical diagnosis here will be that of a chronic myeloid leukemia, CML. Okay. So the first thing is that you have got to make a diagnosis of chronic myeloid leukemia. That is number one. So the peripheral smear findings plus the clinical history is leading on to CML. Now, what is the most sensitive investigation? Now, see, for this, the answer is going to be fish with a PCR. Okay. So either they could have given the option just as a fish or just as PCR. You could have gone for those options. But here, just to make the option more conclusive, they have given fish with PCR. Okay, fish with PCR. So what is fish? It is fluorescence in situ hybridization technique. So see, when you do a fish, you will be able to demonstrate the 922, the reciprocal balance translocation. So in fish, you are trying to demonstrate the 922 translocation. So the typical karyotype of the CML, it is the 922 translocation, and you can either go for a fish or PCR, as I told you. But here again, it's a fish with PCR, so definitely the answer is going to be fish with PCR. Anybody is having any doubt regarding that? Because CML always is an important topic area. You might get questions from the genetics, okay, the translocation that occurs in the CML. So here, they have asked investigation wise. Okay, you have got a clinical diagnosis, and once you have got a clinical diagnosis, how are you going to confirm? So you have got to confirm, and you're going to do a fish with a PCR. Okay, I hope that is clear. Okay, now the next question, another question from hematology. Which of the following is an indicator of poor prognosis in case of a multiple myeloma? So multiple myeloma also is a very, very important topic and a core topic. And this same question has been repeated in many forms in different exams, whether it be the All India exams or the Central Institute exams. So prognostication of multiple myeloma, it's again very, very important. So a simple question here, the answer is going to be serum beta 2 microglobulin. Okay. So I'll just show you in Harrison itself, you have the table that is given for the risk stratification in myeloma. So risk stratification in myeloma, you can stratify based on certain chromosomal abnormalities. That is, there are certain chromosomal abnormalities that would put you at high risk of developing a multiple myeloma. Plus you have the ISS, which is the International Staging System. Okay. So in this International Staging System for multiple myeloma, well, you are having two important markers. So can you just tell me in the chat box, what are those two important markers which will help stage multiple myeloma into stage 1, 2 and 3? You can see here stage 1, 2 and 3. And those two markers are beta 2 microglobulin as well as albumin. All right. Now, in addition to this, okay, in addition to the chromosomal abnormalities as well as the ISS you have got to know regarding beta 2 microglobulin and albumin, there are other features suggestive of high risk disease like de novo plasma cell leukemia, extramedullary disease, and elevated levels of LDH and high risk gene expression profiles. So, these are the prognostic markers for multiple myeloma. Now, why this is very important is for the students who are preparing for the subsequent exam, always remember it's not just this question that is involved, the topic per se is involved, is important. So, what I am trying to tell you is that in the subsequent exams, always when you read multiple myeloma, be more careful, always expect a question from it, okay? Because often in the current entrance exams, questions are not repeated, but again, topics are being repeated. But in case of this question, it has been repeated, multiple number of times, okay? So I hope that is also clear for you, all right? Okay, so there is one line in Harrison also, again, just to show you how important beta 2 microglobulin is. So this beta 2 microglobulin is the single most powerful predictor of survival and can substitute for staging. Again, just to tell you how important beta 2 microglobulin is. And also this table from Harrison, I'll definitely be sharing the PDF of this session after this class in my Telegram group as well. So you can go through this as well. So students, it's always important to know the standard workup of a myeloma. So when you work up a case of myeloma, okay, there are several steps that you actually follow. So investigations to evaluate for clonal plasma cells, for clonal paraprotein, to evaluate end organ damage, and it's always very important to evaluate in every patient with a multiple myeloma regarding the risk stratification, okay, to see that will give you an idea regarding the prognosis, okay. So it is beta 2 microglobulin and serum albumin. So I hope that is very clear, okay. All right, the next question. So the next question is again a simple, straightforward factual questions, because you must understand that for the current NEET PG exam also, remember all the questions were not clinical based. Yes, some were clinical based, some were clinical based apparently, but they were merely factual questions. If you knew your basic facts, you could answer them. This is one such question. A straight, factual question. Thus, they have put it into a clinical scenario. So, somebody was working in the benzene industry for 20 years. So, it's a chemical related question. So, a benzene industry. So, there is some exposure to benzene, and now is complaining of fatigue and frequent infections. Which of the following occupational cancers is most likely? Now, tell me what is going to be the answer. Which cancer is most likely? Well, the answer to this is actually blood cancer. Okay, so benzene, is related to blood cancers. Okay, so blood cancers, remember that benzene, can you tell me which hematological malignancy benzene is most related to? The answer is going to be acute myelogenous leukemia, AML. But is it only, is AML the only hematological condition associated with benzene exposure? No. Can you just tell me what are the other conditions associated with benzene exposure? You can have aplastic anemia. Anything else? Can you let me know in the comment section? Any other? Myelodysplastic syndrome. Now, out of these, the most common one is going to be AML. Now, at least some students have wrote bladder cancer for this question. But again, I feel, it's just a bit of lapse of concentration, because I know that all of you know about benzene and blood cancers, but probably you would have confused benzidine. Okay. So, please remember that benzidine is related to bladder cancer. But the question that was asked here was that of benzene. Okay. So, what is going to be the answer? Hematological malignancy, and as Sabir Ahmed is telling in the comment section, AML. Okay, Anjana is also right, AML. All right. Now here again, this question is also a direct pick. Now this is for the students who are going to appear in the coming exams. If you are an MBBS student, if you ask me, I have not read this, is this present in a textbook? Well, it is present. In fact, in due course of my discussion, you will understand that many of these points are there in your routine standard textbook itself. You know, Harrison itself is making a mention of the suspected carcinogens. So there is a table in Harrison also. So see, regarding benzene, and you can see its association with acute myelogenous leukemia. I already told you the other hematological conditions associated with it also. Okay, all right. So there is a big table in Harrison, okay, regarding various carcinogens and the associated malignancies. So I'll be sharing the PDF in the group. So just go through that, because next time they may ask regarding some other carcinogen. So always remember, questions may not be repeated, but the topics will be repeated. So you have got to be very, very strong in this. Okay. Okay. All right. Now next question, again a hematology question. The question is regarding a software engineer who presents with fatigue. Now this again, see, all these are important topics. Only thing is that they have been put into a clinical perspective. Now for the MBBS students watching this, and I am sure that your seniors who would have written the exam this time also would agree, while you are doing your MBBS, please be punctual in the wards, okay, because I don't think there is any textbook or any coaching that can give you more information than your clinical knowledge that you acquire from the wards. So again, it's a request from my side to be very, very sincere in your ward postings. Okay, maybe you can skip the theory classes of your postings, but again, not the ward classes. Okay, and your ward postings. So it's regarding a software engineer who presents with fatigue and having a sedentary lifestyle. So is sitting in front of the computer for 12 to 14 hours. Even any PG entrance aspirant would also be sitting for the same time, I suppose. So he's taking junk food and is not eating vegetables and fruits. So hemoglobin is 9 and MCV is 120. What is the most likely etiology? Now this again is actually very, very simple. Okay, so I can see a cube is going for B12, some are going for so somebody is telling benzene bladder cancer. No, benzene is not bladder cancer. Benzene is definitely blood cancer. Benzidine is bladder cancer. All right. Okay. Now for this question also, now think from a clinician perspective. So fatigue is there. So there is some anemia, and that anemia on evaluation is found to be a macrocytic anemia. So there is some anemia, and that anemia on evaluation is found to be a macrocytic anemia. Okay. Now you want to find out why this individual has developed anemia. The software engineer to develop anemia, there should be some reason. Okay. So he should be relatively young. Why should he develop anemia? So here again I can see in the comment section a mixture of opinions. Let me, between B12 and folate, let me make it very simple for you. See, he is taking junk food and is not eating vegetables and fruits. See, those who are saying it is B12 deficiency, do you think fruits and vegetables is a rich source of B12? No. Okay. Fruits and vegetables is not a rich source of B12. So if you keep on eating junk food, which is mostly the cooked food, okay, you are ordering some, maybe some tandoori chicken or some junk food you are continuously ordering. So all these are boiled foods. What can happen is that the folate, okay, the folate is actually very, very heat sensitive. Okay, the folate is very heat sensitive. Now since folate is very heat sensitive, so repeated, when you cook, actually what can happen is that can decrease the amount of folates in the diet. So if you don't consume vegetables as well as fruits which will give you folate, that can push you to folate deficiency, and by no means the answer is going to be B12 deficiency. Okay. Now just to substantiate my answer, I'll be just giving you the reference also. So Bethesda Clinical Hematology is the standard book for hematology, clinical hematology. that is where there is a standard book even hematologists actually follow. So you see, I am just quoting a line from Bethesda Hematology. A diet poor in vegetables is the major cause of folic acid deficiency. The cooked vegetables and meat are less satisfactory sources because cooking destroys much of the folate. And in brackets, remember this brackets, this particular line also is there in the book. Okay, so this is also not added by me. This is less of a problem with B12. So this issue is majorly a problem with folate deficiency. Okay, so the answer is going to be folate deficiency and not B12. I hope it is clear. Okay. All right, so that is also very, very clear. So hematology again, so we are seeing a question. See, we had questions from say this macrocytic anemia. Now we'll go on to see that in a short while we'll see that iron deficiency anemia questions were also asked. So hematology was given a considerable weightage this exam. Okay. So next, shall we move on to the next question? It's regarding a 10-year-old girl. Okay. Now tell me, 10-year-old girl presenting with this condition, she is having a dog as a pet. What is going to be the diagnosis? So a similar image was given for the exam, a very boggy swelling, okay, a boggy scalp swelling. Now always remember, when you have data in the question, all these data is going to lead you to some answer. So always search for clues in the question. Okay. All right. So now just see what is going to be the answer here. So yeah, very good. So Justin Abraham, you are absolutely right. So the answer to this question is going to be carryon. So carryon commonly presents as a boggy scalp swelling. So what actually made me go to a diagnosis of carryon? Yes, one is the visual appearance, but there is also a dog as a pet. Now you tell me, what is the relationship between dog as well as your carryon? Can somebody tell me this? Yes. So carryon, it is actually a inflammatory tinea capitis. Okay, and it is caused by the zoonophilic dermatophytes, and the most commonly it is Microsporum canis. There are other organisms also, but again Microsporum canis is very, very important, and Microsporum canis is primarily affecting dogs as well as cats. So in your question you have this, there is a pet dog also, and the patient can present with a boggy swelling with pustulation. So once again, dear children, always remember, this is for the MBBS students and the future aspirants. Whenever you have a clinical question, always search for clues. Yes, you should be a good reader, but whenever you are reading, whenever you are reading a topic, say carryon, you are actually marking Microsporum canis. That time itself it should strike your mind how this an individual can contract this infection. So always keep your thinking hat on, which will actually help you a lot in answering these clinical questions. Okay, because I feel it's not just the quantum of knowledge that you have in hand that determines your performance in the actual exam. It also depends on your clinical acumen. Okay, see how you are able to correlate clinically several history, examination findings, investigations, and then finally come to a diagnosis. Okay, all right, so that is also clear. So carryon is also clear. Now next question is again a simple question. So this is regarding a patient presenting with a tendon xanthoma and has high total cholesterol and high LDL. What is going to be the diagnosis? Lipoprotein lipase deficiency, Tangiers disease, familial hypercholesterolemia, familial hyperchylomicronemia. So what is going to be your answer? So this again, often you can call it a biochemistry question or a medicine question. But remember, this is actually important topic. Okay, so let me hear your answers. Yes, as Dr. Gaurav is rightly saying, this is a familial hypercholesterolemia. Very good. Familial hypercholesterolemia. Now there is actually one table in Harrison. This is for all the junior students, MBBS students. There is one table in Harrison on the primary hyperlipoproteinemias. Okay, And in that you can see the hypercholesterolemias. So familial hypercholesterolemia, the gene defect is a LDL receptor gene defect. You can have tendon xanthomas. Okay, so basically the lipoprotein that is elevated is LDL. Okay, it is LDL that is going to be elevated. Whereas if it was a lipoprotein lipase deficiency, what can you tell me what would have been elevated? Lipoprotein lipase deficiency, just tell me in the comment section what will be elevated. Just let me know. It will be chylomicrons and VLDL. So you have got to get the whole biochemical picture also into hand, because otherwise you might make a silly mistake here. So this is again familial hypercholesterolemia. So familial hypercholesterolemia is actually an autosomal dominant hypercholesterolemia. That is another name. You call it ADH also, autosomal dominant hypercholesterolemia. So there is elevated levels of LDL cholesterol in the absence of raised triglyceride levels. So mutation, I told you, most commonly it is a LDL receptor mutation. So that actually results in the reduced clearance of the LDL from the circulation, which will result in increased levels of LDL cholesterol. Correct? So this is very, very important, this table from Harrison, primary hyperlipoproteinemias, very, very important. Okay? All right. Now next question. Now this again is a question from GIT, again a pathology element to it. So this is regarding a chronic alcoholic patient. Okay, chronic alcoholic patient with increasing abdominal girth and decreased liver span. Liver biopsy is showing hepatocytes with eosinophilic material, cytokeratin positive, and what is the content of inclusions. So first of all, it's regarding a chronic alcoholic patient. So alcoholism would have caused some damage in this patient. Now see the extent of damage that alcohol can cause to the liver. You remember there is one beautiful diagram in your Robbins textbook which actually tells you a lot about this, okay, regarding the normal liver. So initial stages, someone can have steatosis or maybe even an alcoholic hepatitis, but long standing, that can progress on to cirrhosis. Okay, long standing it can progress on to cirrhosis. So let me just see the answers. Yes, Priyanka Singh, you're right. These are intermediate filaments, the Mallory bodies. So I'll tell you, about Mallory bodies. So you see here, this is again in Robbins itself. So whenever you are having an alcoholic damage to the liver, it actually progresses sequentially in several steps. Okay, so the changes, the morphological changes that occur in an alcohol-induced hepatocyte injury, you can have fat accumulation, that is steatosis, okay, cholestasis, ballooning, and cell swelling, cytoplasmic clearing, and very, very importantly, the intermediate filaments, they actually clump. Okay, so there is actually a mass formed by this intermediate filaments, and this mass that is formed by this intermediate filaments is actually called Mallory hyaline. Okay, Mallory hyaline. Now for the MBBS students, I have just taken this directly from your Robbins textbook. So everything is there in your standard textbooks while you are learning. Okay, I just want to reinforce that to you. All right, so just to show you some pictures. Okay, so alcoholic hepatitis, in Robbins itself they have given a beautiful picture also of a patient with an alcoholic hepatitis. Okay, alcoholic hepatitis. So you can have clumping of the intermediate filaments. So you see here the arrow that is pointing to is to the Mallory hyaline. Okay, and you can see the inflammatory cells also clumping there, showing the inflammation, active ongoing inflammation in an alcoholic hepatitis. Now at the same time, in a patient with say alcoholic hepatitis, if you do a liver biopsy and if you do a IHC, now IHC in case of the alcoholic hepatitis, can you tell me why are you doing this? You will do it staining for keratin 8 and keratin 18. Okay, keratin 8 and keratin 18. So you can do the IHC, and that is again telling you that this is a case of alcoholic hepatitis, and you have the Mallory hyaline as well. Okay, so the answer to this question is intermediate filaments. And also just see the early stages. I told you there will be alcoholic steatosis. So alcoholic steatosis, what is the important change that can happen? You can see all these vacuolations in your hepatocytes. So these hepatocytes, the fat will not be stained. So you can see that the fat droplets will appear as clear vacuoles. That is what happens in alcoholic steatosis. Whereas when it goes to the stage of cirrhosis, okay, when it goes to the stage of cirrhosis, this is the gross appearance. You can see the nodular architecture. Okay, even in the histopathology also, the nodular architecture is very well appreciated. So the answer is going to be intermediate filaments. Okay, I hope that is clear. Any doubts on this? Any doubts? Just let me know. All right. Now next question is regarding again a clinical scenario from the endocrinology chapter. So this is regarding a diabetic female. Okay, so the background is that of a diabetic female, and she is having persistent vomiting with history of consuming food from outside. So the blood pressure is on the lower side, pH is 7.52, bicarbonate 26, PaCO2 20, electrolytes sodium 123, potassium 3.2, chloride 67. What is the cause of her ABG findings? Now just let me know what is going to be the answer here. So see, at least for some of you, the first instinct might be a diabetic patient with some acid-base disturbance. Could it be a diabetic ketoacidosis? But first thing you have got to know is that in this question, the pH is actually 7.52. Okay, so the pH is actually 7.52. So it is an alkalotic stage that the patient is actually having. Now, what is the other striking feature in this question? Can somebody tell me what is the striking electrolyte abnormality that is seen in this question? What is the striking electrolyte abnormality? Just let me know. That will help you come to a diagnosis. Yeah, Tariq is saying vomiting is there. I agree, vomiting is there. But you see, what about the chloride levels? So the chloride levels, which should be in the range of say 96 to, Deepika's sodium is low, but again, the striking abnormality is going to be the chloride levels, which is very much low. So the chloride, normally should have been in the range of say 96 to 106 milliequivalents, but you can see the chloride is very much low. So probably what has happened, yes, there are all other abnormalities there in this, the question, but the striking abnormality is that the chloride levels are very much reduced. Okay, so chloride levels significantly reduced. So what do you think now? See, what has happened to this patient is, see, there has been persistent vomiting, and when you have persistent vomiting, you have your gastric secretions all being vomited out. So there is a chloride loss as well. So that actually predisposes the patient to a alkalosis. Okay, so that has actually led on to this the acid-base abnormality. So it is actually a hypochloremic alkalosis that has happened in this patient. Hypochloremic metabolic alkalosis that has happened. Okay. Hypochloremic metabolic alkalosis. Now, what is the reason for this hypochloremic metabolic alkalosis? Is it because of the diabetic ketoacidosis? No. It is because of the persistent vomiting. The answer is going to be persistent vomiting. Okay. Any doubts here? Yeah, Marthan, you are right. There is vomiting hydrochloric acid loss. Correct? Okay. I hope everything is clear. All right. So this is because of the persistent vomiting. Okay. The next question, a patient with loss of right half of the visual field on both sides, probable site of lesion. Again, a very, very simple question. What is going to be the answer? So there is a right homonymous hemianopia. Right homonymous hemianopia. So when you have right homonymous hemianopia as a defect, so what is the likely site of lesion? This is likely to be, out of the options, left optic tract, right occipital lobe, left optic nerve, optic chiasma. The answer is going to be the left optic tract. Okay, left optic tract. So when you have a left optic tract lesion, I am sure that you would have seen this image multiple number of times. I've taken this image from Harrison itself. So when you have a lesion involving a right optic tract, it will lead on to a left homonymous hemianopia. And if it is a right optic tract, a left optic tract lesion, it can lead on to a right homonymous hemianopia. So the answer is going to be a left optic tract lesion. Okay, simple question. Now, being a medical practitioner in India, how would you correctly prescribe alprazolam? So this is again a question with respect to clinical pharmacology. Well, what do you think is going to be the answer? Alprazolam 0.5 mg tab once daily for 7 days, half mg 1 tablet HS for 7 days, 0.5 mg at bedtime for 7 days, 500 microgram 1 tab at bedtime for 7 days. Well, the answer is going to be C. Okay, alprazolam 0.5 mg 1 tablet at bedtime for 7 days. Well, the thing is that when you routinely prescribe to your patients, see, when you write HS, HS is again horosomny, you are having the patient just drug before going to bed. But sometimes, it might not actually make sense to the patient. So the patient actually might buy the drug and he might consume it in the afternoon or morning or whatever time is comfortable for him. So it's again important to have a good communication with the patient and tell him, okay, this is one drug you have got to take at bedtime. So probably, you have the question also being framed like that. Being a medical practitioner in India, so which means, you have got to convince your patient again. So, okay. So, it's not going to be once daily. You cannot just say once daily because you have got to tell the patient when to take it. Okay. When to take it. Alright. So, that is very, very clear. So, you have got to explain to the patient in the simplest terms possible. Okay. I hope that is clear. Okay, so next question, which of the following is a false statement regarding pheochromocytoma? Sorry, I have not mentioned regarding that. So regarding pheochromocytoma, which is a false statement. Option is diagnosed by urine VMA and catecholamines. Treatment of choice is surgical excision. Propranolol is given initially to treat hypertension. Can present with hypertension alone, sometimes with abdominal pain as vomiting. So, regarding pheochromocytoma, first of all, coming to the clinical presentation. So, it can present as hypertension, yes, either as a paroxysmal episodes of hypertension or sustained hypertension. Even abdominal pain and vomiting can be a clinical feature, yes. Now, how will you diagnose pheochromocytoma? Definitely, the biochemical testing is forming an important part of the diagnosis of pheochromocytoma. So diagnosed by urine VMA and catecholamines like your metanephrine, you can either go for in the urine or the plasma. So, the treatment of choice is surgical excision. That again is a true statement. So this is also true. Surgical excision is the treatment of choice. And propranolol is given initially to treat hypertension. Now this is again a basic question, basic pharmacology question. So when you have a patient with pheochromocytoma and you're planning a surgery in this patient, you have got to preoperatively prepare the patient, and preoperatively you will be giving the patient antihypertensives also to control the BP. But always remember, when you use antihypertensives, it is always alpha followed by beta blockade. Okay, alpha followed by beta blockade. So first you will give an alpha blocker like a phenoxybenzamine, and then only you will give a beta blocker. Now what happens when you straight give beta blocker and then maybe go for alpha blocker is that when you go for an initial beta blocker, there will be an unopposed action from the alpha receptors, and that can even push the patient to a hypertensive crisis. Okay, so the answer for that, this is actually a wrong statement. Okay, so propranolol is not given initially to treat the hypertension. Okay, and any other doubts for that? Okay, no doubts. So this is again regarding the clinical features. Again, in Harrison they have given the list of features of pheochromocytoma. You can see that hypertension is there, abdominal pain is there, okay, and this is the flow chart for evaluation of pheochromocytoma. I will be sharing it in the PDF. This is from the Williams textbook of endocrinology. I have taught this also, the same flow chart I have taught you in my class also in the DocTutorials app. So this is the flow chart of evaluation. So initially the biochemical test like your fractionated metanephrines and the fractionated catecholamines is going to help you in the urine or plasma, and then subsequently you will localize, and then you will go for surgical resection as the definite treatment. Okay, that's how you will evaluate. And regarding the drugs used to treat pheochromocytoma, as I told you, initially give alpha blockers like phenoxybenzamine. There are other options also that you can give like prazosin, terazosin, doxazosin. Even alpha plus beta blockers like labetalol, calcium channel blocker like nicardipine, and you can give metyrosine. But again, commonly what is being asked is it is going to be an alpha blocker first followed by a beta blocker. I hope that is clear. Okay, any doubts? No. Alright, now next question. A chronic kidney disease patient is undergoing pyeloplasty. What is the best suited post-op analgesic? See, this is again basic question, basic MBBS level question that you might actually encounter in your internship, okay, or your ward postings. So patient with a chronic kidney disease, do you think you are going to prefer drugs like diclofenac, naproxen, indomethacin? So no, the answer is going to be acetaminophen, because the others are very, very notorious to produce again a worsening of your renal parameters. So just let me know when you have NSAIDs being used in such patients, what is the major problem? What sort of a renal injury do NSAIDs predominantly cause? There are different implications or end results for NSAIDs and kidney, but tell me what is commonly what is the after effect of giving NSAIDs? Where does it act? Well, it predominantly acts on the afferent arteriole. Okay, afferent arteriole. So this can cause a prerenal AKI. Okay, so already the patient has undergone some procedure, so there is likely dehydration, and you do not want to put another NSAIDs also. Okay, so this is very, very important. These drugs should be avoided. But remember, NSAIDs are in the kidney, it not just acts on the afferent arteriole. Remember, it can produce interstitial nephritis as well. Okay, so that is very, very important. Yeah, even papillary necrosis. So multiple effects are there, but commonest is actually acting on the afferent arteriole and causing a prerenal AKI. Okay, all right. Now the next question, a very, very simple question. A patient presents with excessive tiredness. Okay, so there is a excessive tiredness towards the end of the day. So there is some sort of a fatigability that worsens towards evening. That is something that is striking for me in the question, and that improves with rest. So he's having some ptosis, speech difficulty, and some other complaints also, which I could not get the recall. So anyway, he is having, one thing is for sure, he is having fatigability. Okay, so there is a fatigability, and second is he is having some ocular symptoms, plus he is having some bulbar symptoms. Maybe he would have had some weakness also, so most likely this is a generalized myasthenia gravis. So I am sure that on seeing this term fatigability, that would have prompted you to think towards myasthenia gravis. So Lambert-Eaton myasthenic syndrome does not have the classical fatigability. And also, the myasthenia actually starts in and around the face, the ocular muscles, bulbar muscles. But Lambert-Eaton, usually starts in the lower limbs, and later stages only it will have the ocular affection as well as the bulbar affection. So the answer is going to be myasthenia gravis. Why not Duchenne muscular dystrophy? Remember, Duchenne muscular dystrophy. It is a dystrophic condition. It is not going to have any fatigability. It's a muscle disease, but it is not going to have a fatigability. I hope that is clear. Okay? Okay. All right. Fine. Now, this again for my dear MBBS students watching this, there is again a table from a beautiful table, simple table from Harrison. showing how to diagnose myasthenia gravis. So history is important, physical examination, laboratory testing. So some years they might ask a clinical question based on the clinical presentation of myasthenia gravis. Some years, they are more focused regarding the biochemical investigations like the acetylcholine receptor antibody. Sometimes they may ask regarding the electrophysiological investigations like repetitive nerve stimulation or a single fiber EMG they might ask, or even simple questions like ice pack test. So remember that myasthenia is a very, very important topic. So how do you identify myasthenia from the history, from the examination, and how will you investigate this patient? And that is both the biochemical as well as the electrophysiological. Very, very important. Simple table. Okay. All right. So next question again from cardiology. A mid-diastolic murmur with a prominent A waves in JVP is seen in. Come on guys, what is going to be the answer? MDM with prominent A waves. I know many students have this confusion between these two options, mitral stenosis and tricuspid stenosis. So you just tell me, what is going to be the answer here? Is it going to be mitral stenosis or tricuspid stenosis? Because both of them can actually produce a mid-diastolic murmur. So just tell me what is going to be the answer here. Well, the answer here is going to be mitral stenosis without any doubt. Okay. Okay, so mitral stenosis is going to be the answer. Okay. Do you have any doubts in that? Mitral stenosis or tricuspid stenosis? It is not mitral stenosis, it is tricuspid stenosis. Why not mitral stenosis? Because see, Kuldeep, you have written mitral stenosis. Why it is not mitral stenosis is because mitral stenosis can also produce prominent A waves. But remember that occurs only in very late stages. If you have a mitral stenosis, subsequent, you should have a right heart involvement and then only you will have a prominent A waves. So MDM seen in both. Prominent A waves also can be seen in case of mitral stenosis as well as tricuspid stenosis. But the issue here is, many of you went for mitral stenosis because you know mitral stenosis to be a common condition than the rare tricuspid stenosis. And one student actually inboxed me in my message, isn't tricuspid stenosis a rare condition? It is a rare condition, but again, when it is mentioned in the option and you are having a prominent A waves, I'll just show you a figure. This is one of the figures I have shown you in the quick revision program session also regarding large A waves in case of tricuspid stenosis. Exactly the same image I have shown you in the quick revision program. Okay, so that is going to be a tricuspid stenosis. Okay, all right. So very, very clear. All right. Now the next question is again a clinical pharmacology question. So a female taking oral contraceptives developed tuberculosis. So after prescribing the anti-tubercular therapy, physician advised the patient for barrier method of contraception. What is the probable reason? Again, very, very simple question. I am not putting much time into this. Okay, just let me know what is going to be the answer. Why is it? Is it because oral contraceptives decrease the efficacy of anti-tubercular, or is it because rifampicin decreases the efficacy of oral contraceptives? Answer is going to be D. Why D? Because rifampicin will induce, it's an enzyme inducer, and the efficacy okay, Sanket got a heart attack initially, all right. So rifampicin will actually decrease the efficacy of oral contraceptive. Because why? It is an enzyme inducer. As all of you have rightly said, the answer is going to be D. All right. So next one, again a very simple question. A 30-year-old male weighing 70 kilogram has a serum sodium of 120. What is going to be the sodium deficit? Again, very, very simple question. All you have got to know is how to calculate this sodium deficit. Well, the sodium deficit, the formula is the total body water percentage into weight, okay, into the difference, that is the desired sodium minus the actual sodium. Now coming to this question, you see, for the total body water, if it is percentage, it is going to be 0.6 for men and 0.5 for women. So if the recall is correct, It is going to be, the language of the question. I suppose some patient was given lorazepam or something. That is what I suppose. Correct? Achan Khan, am I right? Patient was given lorazepam, but the rest of the question is same. The sodium value of 120. So the total body water percentage, since it is going to be a male, it is going to be 0.6 and into the weight is actually 70 kilogram into desired sodium minus actual sodium. So see, 136 to 145 is the normal sodium, and let's put a value of 140. Okay, a 140 as the desired sodium minus the current sodium. So it is 0.6 into 70 into 20, and what is going to be the answer? 840. Okay, 840. So the answer is going to be 840. It is going to be option C. Acube, it's not D, it is going to be 840. 840 is the answer. Smita Patil, you are right. Okay, so 840 is going to be the answer. Okay, all right. Very clear. Okay. Next, again, a very, very simple question. So the question is, a female patient feels numb on the fingertip. Her facial skin was tightened and ANA was found to be positive. Immunofluorescence shows nucleolar pattern. Again, a question from rheumatology, and it is very, very unusual to find a medicine paper in any exam without a question being asked on the autoantibodies or immunofluorescence in any of the rheumatological conditions. Now see, the patient is having some numbness on the fingertip, and I also get a recall that the students gave me a recall that the patients are going to have, patient was also having features of Raynaud's phenomenon. I did not get the exact recall, but somebody told me there was features of Raynaud's phenomenon also. Now the facial skin was tightened and ANA nucleolar pattern. So the answer is actually quite obvious here. It is going to be systemic sclerosis. Now that is quite clear. It is systemic sclerosis. But can you tell me, is this likely to be a limited cutaneous systemic sclerosis or a diffuse form? Can you just tell me regarding that? Is it going to be a limited cutaneous or a diffuse one? Just let me know. Limited cutaneous or diffuse? I just want to know, if it was, they are given the options limited cutaneous or diffuse. So Ananya says diffuse. So I can see mixture, Smita, Kuldeep, diffuse, Achan Khan, Anish saying limited, diffuse, limited. So it's a mixture. So it's almost a 50-50 poll. Okay. See, the answer is this is a limited cutaneous form. So why is it a limited cutaneous form? See, first it is beginning with features of Raynaud's phenomenon. Okay. And the immunofluorescence pattern of nucleolar pattern. Now if you remember, there is one table in Harrison. I have taken this in my lectures also in the DocTutorials app. So there are various immunofluorescence patterns in case of systemic sclerosis depending on the target antigen. Different antigens can have different immunofluorescence pattern. So you see here the nucleolar pattern, okay, nucleolar pattern is commonly associated with the limited cutaneous form, okay, is commonly associated with. So rarely diffuse cutaneous can happen, but mostly it is limited cutaneous form, the nucleolar pattern of immunofluorescence. And not just that, not just based on the immunofluorescence pattern, because again, this is also one very, very important table. Remember when I taught you the lectures also, I showed you this very important table from Harrison. This is again, especially to the students who are preparing now. See, there is a beautiful table in Harrison which shows you the differences between the limited cutaneous and diffuse cutaneous form. So even in limited cutaneous, you can have a skin involvement to begin with distal to the elbow, and also it can involve the face, okay, and it has a slow progression. So the point here is you can have a limited cutaneous form presenting with Raynaud's phenomenon that is involving the face also. So don't think that face is going to be spared. Can you tell me what is often going to be spared in a limited cutaneous form? Can somebody tell me? Well, it is going to be the trunk that is going to be spared in case of a limited cutaneous form. The face is not going to be spared. So limited cutaneous can very well present with features suggestive of Raynaud's phenomenon, thick skin, especially towards the face and distal to the elbow, and nucleolar pattern of immunofluorescence also is again giving you more suggestion that this could be a limited cutaneous. Yes, there are other, you know that the limited cutaneous form is having a centromeric pattern, I agree with that. The diffuse cutaneous is having a speckled pattern, correct. But remember this time they were asking regarding the nucleolar pattern, okay. Alright. So Mallikan Reddy, I know that only systemic sclerosis was given in the option, I know that, but I was just asking you a question. If at all, you know, the examiner asks, is this more likely to be a limited or diffuse cutaneous? The answer is going to be limited cutaneous. Okay, I hope that is clear. Okay, all right. So next question, a 68-year-old male. You must tell me the answer, just type in the comment section. So this is again a respiratory system question based on a case of pneumonia. This is again management. You remember children, I told you lot of questions actually came from the management part. How are you going to manage a patient? So 68-year-old male with cough, sputum and cough and sputum production and auscultation showing bronchial breath sounds. Okay, auscultation showing bronchial breath sounds. There is no confusion, respiratory rate 20 per minute, urea 44, BP 110/70. What is the next step in the management? Well, this is again a question that is based on the CURB 65 score in pneumonia. So I have told in my QRP sessions also that one of the scoring system, either the ABCD2 scoring system for a TIA or scoring system like a CURB 65 for pneumonia, or you might have a well score for pulmonary embolism, though that is not a per se scoring, but certain scoring systems are again favorite areas for examiners. So this again is CURB 65. I think this has been asked quite a number of times in the previous exams also. So you can take it to be a repeat question. Now the answer to this, tell me what is the answer to this? Well, you have got to calculate the CURB 65, and what is the CURB 65 score here? The CURB 65 score is going to be 2. Now if any student does not know how to calculate the CURB 65 score, I'll just show you the the flow chart of calculating the CURB 65 score. So CURB 65, CURB, confusion, urea, respiratory rate, blood pressure and age. So confusion, remember in the question they have specifically said there is no confusion. Urea more than 7 millimole, which means a blood urea nitrogen more than 20 milligram percentage, or a blood urea which is more than 40 milligram percentage. That is what it means. Blood urea nitrogen more than 20 or a blood urea more than 40. So here what was the blood urea? The level was 44. Okay. Now respiratory rate more than 30, blood pressure less than 90/60, age more than 65. So here the age was 68 years. So there is 1 point to the urea part and 1 point to the age part, because you see each will have a 0.1. So the total score is 2. Now what is the importance of CURB 65? It will help you in decision making in case of in a patient with pneumonia. So if the score was 0 or 1, you could actually send the patient home with antibiotics. Whereas if the score is 2, you have got to admit the patient, which is important. And is an ICU needed? No, ICU is not needed. So in a non-ICU setup in the ward, you can admit the patient. However, a high score means you have got to admit the patient in the ICU. Okay, all right. So this is very, very important. So, and all these tables which I am showing in this class, I will be sharing with you in my Telegram group. So you can just text me also. This is my number 9447. This is my WhatsApp as well as Telegram number. So if you text me, I'll send you the link of my Telegram group so that you can join, and I'll be putting the PDF there. Okay, all right. So fine. Now next question. 54-year-old male presents a patient, 54-year-old male patient from Chhattisgarh having progressive motor symptoms and leg cramps since 1 month. What history will you inquire for making a diagnosis? So this is again a neurology question. So this is again a very simple question, I should say, because only thing is that you have got to make a diagnosis here. Now some students in the recall that they gave me, they were saying that there was spasticity also in the question. So can you just let me know if spasticity was there or not? Even if it was not there, it doesn't make much difference, but again, if it is spasticity, it makes the answer more conclusive. That's it. So see, the answer here is going to be a diet history. Okay, this is going to be a diet history. Diet history. So many of you have answered as diet history, some are going for vaccination history. So the diet history is the answer, because see, this is actually a case of a probable spastic myelopathy. And so Smriti is asking why not Guillain-Barré syndrome. Alright, so I'll tell you. So Smriti, this presentation is actually with a pure motor syndrome, correct? And the patient is having, leg cramps since 1 month. So one, they have given a history of a place, they have specifically written as Chhattisgarh. So there has to be, some relation to the locality as well. And next point is, because if it was GBS, there is no point why they should give the name of a place. Okay, all right. So next is, the leg cramps is also given. Leg cramps is not a common feature of your, Guillain-Barré syndrome. Okay, so and also the Guillain-Barré syndrome, the patient, they would be mentioning points like areflexic weakness. Certain other points also will be there, which is not there in the question. Okay, all right. So that is again clear. Now I'll tell you about neurolatyrism. See, I told you this is a spastic myelopathy, and probably this is a case of neurolatyrism. And it is important to ask for the dietary history. Why is it important to ask for the dietary history? Because this is often caused by consumption of flour from the chickling pea, that is Lathyrus sativus. And why does this Lathyrus sativus cause a spastic myelopathy is because it contains a toxin by name beta-oxalyl aminoalanin. Now this is an excitotoxic neurotoxin. What is it? This is a excitotoxic neurotoxin. Excitotoxic neurotoxin. So this is a AMPA glutamate receptor agonist. Okay, excitotoxic neurotoxin. So what happens is that there is increased levels of reactive oxygen species, as well as there is an impairment of the mitochondrial oxidative phosphorylation. And the majority of the damage because of the reactive oxygen species, as well as the impairment of the mitochondrial oxidative phosphorylation, the majority of the damage occurs in the bed cells. Okay, you know about bed cells. So you can have bed cells involvement. You can even have the spinal cord involvement also. Okay, so bed cells involvement, you can have a myelopathy also. So the corticospinal tract is actually preferentially affected. Okay, so this develops as a spastic paraparesis with leg cramps, paresthesias and numbness accompanied by bladder symptoms as well as impotence. Okay, so that is it regarding neurolatyrism. Any doubt? Any doubt? Now just let me know one thing, whether stiffness was mentioned, because I see Smriti actually saying that stiffness is mentioned. If stiffness is mentioned, I told you, then that makes the answer more conclusive, because Guillain-Barré syndrome, you are not going to have a stiffness. Why are you not going to have a stiffness in Guillain-Barré syndrome? GBS or Guillain-Barré is an element syndrome. So element syndrome is going to have a relatively flaccid weakness, whereas in case of neurolatyrism, it is going to be a spastic myelopathy and a spastic weakness. So consumption of the pulses, that actually results in neurolatyrism. Okay. Okay, so any doubt here? So Siddhartha, you're asking why not capsular stroke? See, look at the history, you know, there is a progressive nature since 1 month, you know, progressive for 1 month. So do you think a stroke is going to progress for 1 month? Stroke is an acute event, right? It is not going to have a progressive course. All right, so that is clear. Now, next question is a patient with vomiting. This is actually a common clinical scenario. If you are working, you know, if you have done your internship in any hospital with a good caseload, a reasonably good caseload, you would have seen this condition. Definitely yes. Because the patient with vomiting, you know, might have been treated with some antiemetics in from peripheral hospital. So you know that some of the antiemetics are dopamine receptor antagonist. So the symptoms would be relieved, but later, you know, he develops abnormal movements, and what is the drug to be prescribed? So as I said earlier, often when you give antiemetics, often what happens is that in some of the peripheral health centers, sometimes, you know, some clinician might repeatedly give, dopamine receptor antagonist. So that actually results in a dopamine receptor blockade, and that can result in abnormal movements. So you can have a dystonia that is going to develop. Okay, dystonia that is going to develop. So when you have a dystonia that develops, you tell me what is going to be the management. So as many of you rightly said, benzhexol. So you have got to give anticholinergics. So either benzhexol, or can you tell me some other agent which is slightly more preferred? If that was in the option, you could have picked that also. Okay, instead of benzhexol, if that was there, you know, it would have been an even better answer. What is going to be the answer? It is going to be trihexyphenidyl. Okay, trihexyphenidyl. So this is just again a table showing the medical management of dystonia. So when you have a patient with dystonia, you can go for a medical management. Even you can even go for a botulinum injection. But in this case, you know, medical management is very fine. So you can have different drugs with different mechanism of action useful in dystonia. The question asked here is regarding anticholinergic, that is trihexyphenidyl, which is useful in dystonia. And then you can use dopaminergic agents also, certain dystonias. Okay, well, I am not going too much into detail in which are the dystonias. You know, at least some of you I have taught you regarding the levodopa responsive dystonias, dopa responsive dystonias. So then GABA receptor mediated clonazepam and baclofen also can be given. In this question, it is going to be trihexyphenidyl, that is going to be the answer. Okay, all right. Okay, so that is also clear. Now, next question. All are side effects of cocaine toxicity except. So just let me know what is going to be the answer. All are side effects of cocaine toxicity except. Just let me know what is the answer. Just hold on for 1 second, okay. Alright, so what is going to be the answer? Cocaine toxicity, yes, answer is going to be bradycardia. Answer is going to be bradycardia. Now this question, do you know, dear students, this is again, this question is also, the answer to this question is there in our Harrison. Okay, so I was seeing many of them, you know, searching for many other references, but remember this is also there in Harrison. I'll just show you the table. You see there is a specific table in the later part, the toxicology part of Harrison, regarding the complications of cocaine use. So you see cardiac ischemia is there, so that can predispose to myocardial infarction. So lot of cardiovascular effects are there for cocaine, and you see they are specifically mentioning it as tachycardia, not bradycardia. But if you ask me, rarely it can produce bradycardia also. but it is mostly tachycardia. Okay, mostly tachycardia. So it can produce cardiac ischemia, and it can have central and peripheral nervous system effects. You can have hyperthermia as well as psychomotor agitation. Okay, and again the table is actually a big exhaustive table, but again the examiner has chosen to ask a slightly difficult question. At least some of you were not prepared for this. So Sneha, why can't it be hyperthermia? The answer is because in Harrison there is hyperthermia has been mentioned as a clinical feature, and it is actually a common clinical feature also. Okay, so it is hyperthermia, it is not a false statement. So the answer is going to be bradycardia, because hyperthermia is a feature. Instead of bradycardia, it should have been tachycardia, myocardial infarction it can cause, agitation also it can cause. Clear? Okay. So I hope your confusion is solved, Dr. Sneha. Okay. Okay. Now next, the question is regarding a patient with a 70% burns. A test was done on a sample collected from the burn site. That test is being shown. An obligate aerobe bacterium was isolated from the burns victim. What is the likely organism? So this is again a question from infectious diseases. Again, a bit of microbiology also into it. So whenever you have a burns infection, I'm sure even any MBBS student would think first of which organism. It's going to be Pseudomonas. Okay, so most likely it is going to be some Pseudomonas infection. So, and they have specifically told you also an obligate aerobe bacterium was isolated, which Pseudomonas is. And there is some test being done. So can you tell me what is this test? Can somebody tell me what is the test here? What is the test? Can somebody tell me? Pseudomonas is definitely the answer, but what is the test that is commonly used? What is the test? Yeah, very good. So this is actually the oxidase test. So see, the question itself, first of all, burn site infection and obligate aerobe, I am almost coming to Pseudomonas. Actually, even if I don't know what is the test, I'll get to the answer, because most likely this is Pseudomonas. So, but still, let me tell you, in the tests for diagnosing Pseudomonas, two important tests, one is a positive reaction in the oxidase test. Okay, so you have the oxidase strip, and into that filter paper strip, if you smear the organisms, that is whatever material was connected from the burn site, if you smear onto the filter paper, you would get a positive reaction, which is actually showing this violet color. And so another reaction is inability to ferment lactose on McConkey agar. So both these will actually give you an indicator that this is going to be Pseudomonas infection. Okay, very clear. Okay, shall we move ahead? Okay. Now next is regarding a 10-year-old AIDS patient who presented with fever, cough, yellowish sputum production. Examination shows bronchial breath sounds and crepitations. At least some of you in the recall, they told me the oscillatory findings were not like this, it was not mentioned, whatever it is. The X-ray shows right lower lobe consolidation, CD4 count is 55. What is the most common cause of this condition? What is the most common cause of this condition? So anyway, it is coming to a lobar consolidation. So what is going to be the most common cause? So I can see Kuldeep going for pneumocystis jirovecii, and pneumocystis jirovecii is to be pronounced as jirovecii, which is the correct pronunciation. Okay. So many of them are going for pneumocystis, some are going for Streptococcus pneumoniae. Well, the answer to this question is going to be Streptococcus pneumoniae, without any doubt. Okay. Now, why is it so? Because, in a retropositive patient, HIV positive patient who is immunocompromised. Now, suppose this patient is admitted in your ward. I am sure many of you have worked in, tertiary care hospitals. If a retropositive patient is admitted in your ward and the patient is having pneumonia, and CD4 count is 55. Is your first clinical possibility pneumocystis? No, because they have specifically asked you what is the most common organism that is responsible. So remember, most common organism that causes pneumonia in a retro patient, whatever be the CD4 count, is going to be pneumococcus. Okay, is going to be pneumococcus. So I'll just show you, for those who are having again doubts, again I'll bring back Harrison here. See, Harrison, let me tell you, I am not a strong believer that Harrison is the gold standard book of medicine. I don't think so, because many places Harrison, I personally don't like certain chapters in Harrison, the way it is written. Okay, I've seen better books than that. So the point I'm trying to tell you is, but for a MBBS student, when it comes as a reference book, Harrison should be taken. Okay. Whereas for the treatment aspects, if you see a book, 20th edition Harrison was published in somewhere in 2018. So now we are in 2021. So if you just quote Harrison for your treatment guidelines, you won't stand anywhere. Which is why in my lectures also, I've always in the DocTutorials app, for management part, I have always quoted recent guidelines. Okay, because a book that was published in 2018 will always lag behind the treatment guidelines. Okay. However, for MBBS students, let me tell you, I always say, when you watch my lectures, first watch my lectures, then quickly retrospectively read Harrison. Okay. It's always good to read Harrison, but again, I would go for a more selective reading than a cover to cover reading, because most of the points that are there in Harrison, I would have covered in my lectures. Okay. But again, especially the management part, I would have covered it, rather than the old stuff in Harrison, I would have covered the latest updated one. But again, coming back to Harrison, certain important, key points here. You see, the pulmonary disease is one of the important complications of HIV. Now you see, patients with HIV infections are particularly prone to infections with encapsulated organisms like pneumococcus and H. influenza, responsible for most cases of bacterial pneumonia in patients with AIDS. So first of all, any pneumonia in a retro patient, first you suspect bacterial pneumonia. Okay. And pneumococcus may be the earliest serious infection to occur in patients with HIV, including, it can cause pneumonia, sinusitis, bacteremia. Now, just because the CD4 has gone to 55, it doesn't mean that the patient is not going to develop a pneumococcus pneumonia. In fact, more immunosuppressed the patient it is, more chance of developing pneumococcus. Only thing is that when you go to the lower CD4 counts, the other atypical organisms, are likely. Okay. So Amnesh, no, it is not like that. See, don't think that, strep is more than 200 and, something is less than 55. The only thing is that if the CD4 count is more than 200, it is very unlikely that you are going to have a pneumocystis infection. That is a correct statement. Doesn't mean that a 55 CD4 count protects a retrovirus patient from, a pneumococcal infection. That concept is absolutely wrong. Okay. So I hope, it is clear to you. Anvesh, you suspected, but the CD4, that is immaterial, CD4 is less than 50, more chance of pneumococcus. Remember, the question is, what is the most common cause? I will not ask you anything. I just ask you, if this patient is admitted in your ward, is the first organism, pneumocystis that you are going to suspect. Okay. All right. Fine. Next question. A patient with giant cell arteritis presents with a history of headache, jaw claudication, polymyalgia rheumatica and mononeuritis multiplex. What should be the first line of treatment? Now this again I have taught you all in my lectures also. Remember, I told you in Harrison, they have given just vaguely regarding the manifestation. But see, in the lectures also I have taught you this particular flow chart from Kelly's textbook of rheumatology, which is the standard textbook of rheumatology. The world standard textbook of rheumatology is Kelly's rheumatology. And you see, whenever a giant cell arteritis is suspected, so if there is an acute, this is actually the flow chart of management of giant cell arteritis. So you see, you can either go for a steroid. If acute visual loss is there, you should go for a pulse steroids. And if there is no acute visual loss, you can go for an oral steroid. So IV might not be required, you can go for oral. Then you can confirm the diagnosis by biopsy or imaging. Okay. Now see, you have already gone for steroids first. So first line is steroids. Then you confirm the diagnosis by biopsy. Okay. And patient is at high risk of complications from steroids. Okay. And then if there is a high risk of complications of steroids, only then you will go for tocilizumab. Okay. So if there is no contraindication for tocilizumab, you will go for tocilizumab. The point I want to re-emphasize is first steroids, and then only you are going to consider agents like tocilizumab. Okay. All right. So I hope that is clear. This flowchart also will be there in the PDF. I'll be sharing that. Don't worry. In case you could not take it down, I'll share it in my Telegram group. Okay. All right. Another question. A patient on digoxin. Now this is again a question from clinical pharmacology. At least some of the students will be wondering, what is this clinical pharmacology? See, when you learn pharmacology as a subject, it has always to be integrated with medicine. These are not standalone subjects. So that is the theme, they have got to have integrated learning now. So the students who are preparing for the further exams, aspirants who are preparing, so you should also keep in mind that whenever you learn some topic, pharmacology, always give that a clinical perspective. Again, I reiterate, please be sincere in your ward postings. Okay, do not skip your ward postings for any other class. It's very, very important. So patient is on digoxin and he is on some other concomitant medications also. So at presentation he is having some atrial fibrillation with a controlled ventricular rate, and somehow his digoxin levels has raised from the previous value. So patient was on digoxin plus some other medications, and currently he is having a digoxin toxicity. Okay. So which of the following medications has enhanced digoxin toxicity? So what do you think is going to be the answer here? KCl, clarithromycin. So I can see many of you going for clarithromycin, some of you, one or two going for KCl, and maybe one going for triamterene. See, the answer here is going to be clarithromycin, but you guys tell me, why is the answer clarithromycin? You guys tell me, why is the answer clarithromycin? Can you just let me know? Why is the answer clarithromycin? Well, for this, again, let me tell you, drug interaction is very important. When you learn pharmacology, always, sometimes you might learn the mechanism of action of a drug, its actions, its dosing, its adverse effects, its contraindications, but sometimes you tend to miss out on the drug interactions. Whether it be, drugs like in cardiovascular system or the anti-epileptics in neurology, this is often the case. So the answer to this question is clarithromycin. Now the reason is, yes, there are two reasons for this. Okay, there are two possible mechanisms of interaction of clarithromycin with digoxin. One is a major mechanism, which as rightly Dr. Sonam and Dr. Anjana is saying. You're right, the major mechanism of interaction between these two drugs is that there is a strong P-glycoprotein inhibition by clarithromycin, okay, as digoxin is a P-glycoprotein substrate, which means it can increase the level of digoxin, okay. So this clarithromycin inhibits the P-glycoprotein, and digoxin is actually a P-glycoprotein substrate, so the levels of digoxin increases. But in a small subset of population, another mechanism was also suggested. So these are two possible mechanisms of interaction of clarithromycin and digoxin. With the first mechanism, this one is the most accepted mechanism. There is also a second mechanism which I think you should know since the question has been asked. So that is with respect to the gut. Okay, that is, in a small subset of individuals, the gut bacteria will, play a part in digoxin metabolism. So these macrolides will eliminate such bacterium like Eubacterium lentum, and that may actually increase the bioavailability of digoxin. All right. So that is why, again, because of affection of your gut flora, that again can predispose to digoxin toxicity. These two are the mechanisms. Okay. So this is again very important interactions. Now next time, they might ask some other drug interaction of digoxin, okay, which is very important. Digoxin, very important topic from pharmacology, okay. All right. Now next question. A patient on steroid therapy and having chronic urticaria now develops respiratory distress. The bronchoalveolar lavage was done and a larva was seen. What is the likely parasite? So this question from infectious diseases, what is going to be your answer? What is going to be your answer here? So the answer to this question is going to be strongyloids. The answer to this question is going to be strongyloids. Okay. Now I'll tell you why. See, strongyloids, strongylodiasis is actually caused by Strongyloids stercoralis. Now you see the patient is actually on steroid therapy, which means definitely it is an immunocompromised patient. Okay. So he's having some immunosuppression, that is quite clear. Now any exam you take, All India or maybe the INICT exam, there will be some question related to immunosuppressed state or immunocompromised state. So this is regarding a larva that is isolated from the bronchoalveolar lavage in patients who are on steroid therapy, who is on a steroid therapy. So this strongyloids, the larva can actually penetrate the skin, okay, and this can migrate to the lungs and then finally, it settles in the small intestine. So the larva of strongyloids is having a phase of migration in the lungs as well, okay, because if some organism has to be demonstrated in the bronchoalveolar lavage fluid, something is quite obvious that it has to have a lung phase as well, pulmonary phase as well. So how does strongyloidiasis clinically present? So if it is uncomplicated strongyloidiasis, the patients will be mostly asymptomatic, or he can have mild cutaneous or abdominal symptoms. Now among the cutaneous symptoms, the most common manifestation is recurrent urticaria, okay. So the migrating larva can also have a serpiginous eruption, which is called as the larva currents. Important, larva currents or running larva. You can see this is an image showing the larva currents of strongyloids. Okay, so it is appearing as a pruritic lesion. Okay, it is appearing as a pruritic lesion, and you can see it as a almost like a running larva. Okay, whereas patients who are on immunocompromised state or maybe on some immunosuppressants, those are the individuals who will have a disseminated strongyloid infection. So dissemination is more likely, that is a multi-system involvement is more likely when an individual is immunosuppressed. So disseminated form, you can see the organism developing, the organism can cause hyperinfection as well as dissemination, resulting in cough, shortness of breath, or even the hemoptysis. Okay, and when you have this disseminated strongyloids, you see I have taken this directly from Harrison. So from either the sputum or bronchoalveolar lavage fluid or a surgical drainage fluid, you will be able to demonstrate the organism. Okay, very clear. Okay, so this is again I have taken it from a case report, a bowel fluid study showing the Strongyloids stercoralis larva. Okay, all right, so that is again very clear. So I told you disseminated infection, you can obtain it from sputum, the bowel fluid or a surgical drainage fluid. Next is again a very simple question. A female with hysteria was hyperventilating. So this time there were a few questions, at least I think 4 questions based on ABG, but again mostly they were simple questions. So the patient was actually hyperventilating here and he developed carpopedal spasm. So hyperventilation, carbon dioxide washout, tell me what is going to be the abnormality commonly associated with the carpopedal spasm leading on to hypocalcemia. Yeah, this is going to be a simple one. This is going to be respiratory alkalosis. Okay, all right, respiratory alkalosis, simple one. Okay, now in iron deficiency anemia, all are increased except. In iron deficiency anemia, all are increased except. So what's going to be the answer? All are increased except TIBC, transferrin saturation, RBC protoporphyrin, transferrin receptor protein. Just tell me, what is going to be the answer? Iron deficiency anemia, TIBC, transferrin saturation, RBC protoporphyrin, transferrin receptor protein. So you see, there is one table in Harrison where you see the different stages of iron deficiency and the associated biochemical abnormality. So in case of iron deficiency anemia, you can see the levels of the RBC protoporphyrin. So the levels are very much elevated. Okay, you can see the levels of TIBC is also very much elevated. Okay, but the levels of transferrin saturation will be decreased. The transferrin receptor protein also will be elevated. So the answer is going to be what? Transferrin saturation. Okay, transferrin saturation. I hope it is clear. Okay, next question. 23-year-old male complains of low back stiffness. Okay, and also there is early morning stiffness as well for 30 minutes since 2 years. Now complains of bilateral heel pain. So eyes were always red looking. What is the most common cause? Very simple one. So this is actually regarding a young male. Okay, young male. So he is having a low back pain. He is having morning stiffness. See, young male, low backache, morning stiffness. So remember that, just consider these three words. Do you think ankylosing spondylitis is the first the clinical diagnosis you will entertain? No. It can be a very much a mechanical low back pain. But there are certain features, the early morning stiffness actually was lasting for more than 30 minutes. So in case of a mechanical low back pain, the pain would actually last for less than 30 minutes. Okay, I will be just showing you a table as well on the differences between an inflammatory back pain as seen in conditions like ankylosing spondylitis versus mechanical back pain. So young male, low backache, morning stiffness, but see two other very, very important features. He is complaining of bilateral heel pain. Now this again will take you to a condition called like ankylosing spondylitis, because that is very well known to produce enthesitis. So the axial spondyloarthritis is very well known to produce enthesitis, which means inflammation at the site where the Achilles tendon will insert to the bone. So there can be enthesitis, and also eyes were red looking, so there is features suggestive of uveitis. Okay, features suggestive of uveitis. So this is regarding the criteria for the axial spondyloarthritis. So remember, this is going to be an inflammatory back pain. So in addition to arthritis, there will be also enthesitis, anterior uveitis as well. Okay, and these are the differences between the inflammatory low back pain and the mechanical low back pain. So remember, inflammatory low back pain will always last longer and compared to a mechanical low back pain, which will have a lower, the shorter duration of illness. But most importantly, mechanical low back pain, there will be acute history. So maybe, he actually lifted something and then there was a pain. But an insidious onset and subsequent progression is more favoring a inflammatory low back pain. So this will be there in the PDF that I will be sharing in my Telegram group. Okay, alright. So that's clear. Now again, a radiology question also was there based on ankylosing spondylitis. So 40-year-old male presented with low backache, early morning stiffness lasting for more than 30 minutes and chest expansion less than 3 centimeter. The X-ray is shown. What is going to be the diagnosis? Just tell me what is going to be the diagnosis here. Again, a very simple one. Ankylosing spondylitis, again low back pain, then early morning stiffness more than 30 minutes, limited chest expansion. You see, whenever you learn your clinical medicine also, one of the differentials you are learning in limited chest expansion is ankylosing spondylitis. So the X-ray is actually showing features suggestive of ankylosing spondylitis. What I heard from the recall is that there were syndesmophytes which were bridging adjacent vertebra, leading on to a bamboo spine appearance. Okay, leading on to bamboo spine. And to all the future students learning for the exam, you will have questions either from say bamboo spine, radiology wise bamboo spine, or maybe another exam they can ask you regarding the dagger spine, or maybe regarding the shiny corner sign. I'm not going into the details. Okay, so these are the probable other radiological questions also that can come from this topic. Okay, all right. Now next question, again a clinical question with pathology also into this. Patient presenting with anemia, bone pain and hepatosplenomegaly, bone marrow finding is shown, what is going to be the diagnosis? Very simple one. So the bone marrow study was actually showing, can you tell me what is going to be the feature? This is a crumpled tissue paper appearance. So crumpled tissue paper appearance is seen often with Gaucher's disease. The enzyme deficiency is a glucocerebrosidase. Okay, this again is direct pick from standard textbooks. I have just taken this as a screenshot from Robbins pathology. You can see they themselves have mentioned regarding a fibrillary appearance of cytoplasm like a crumpled tissue paper. So at least to the the junior students, what I want to tell you is, if you are preparing, if you are in your first year MBBS, second year MBBS, just follow your classes also very sincerely. Yes, definitely teachers like us can help you, but I think if you are in your MBBS days, you can follow standard textbooks. So if you are watching my medicine lectures, what I always say is that first go for the lectures, watch it, make your own self-made notes, and then quickly retrospectively read Harrison. Okay, all right. So Gaucher's disease, so it's basically the crumpled appearance is because of the glucocerebrosides accumulating. And even in Robbins also they have given a picture of the crumpled tissue paper appearance. Okay, two different stains they have given, the right stain as well as the H&E stain. Okay, all right. The next question. So patient with presents with generalized fatigue and tiredness. The preliminary clinical examination is uneventful. Total WBC count and differentials count normal, no immature cells. What you could see is that in this patient with a generalized fatigue and tiredness, there is lymphadenopathy. But the next part of the question, the second part of the question is what is going to lead you to the diagnosis. That is, the biopsy is actually showing an effaced architecture, intended nucleus and prominent nucleolus containing atypical cells. So there is some cleavage in the nucleus also, there is some indentation in the nucleus. CD10 and BCL2 positive, what is going to be the diagnosis? Yes, the answer is going to be follicular lymphoma. Okay. Now see, follicular lymphoma, multiple clues are there. One is clinical feature. Yes, it can present with fatigue, tiredness and examination showing lymphadenopathy. But what is going to clinch the diagnosis is regarding the biopsy findings. So you see here regarding the immunohistochemistry also, they will definitely ask you. Well, this is definitely a pathology question as well as a medicine pathology integrated question. So the immunophenotyping in case of Hodgkin's, in case of follicular lymphoma, this is again a screenshot from Harrison. You have CD19, 20, 10 and BCL6 positive. Okay, CD5 and CD23 are negative, and translocation 14, 18 and abnormal expression of BCL2 protein. Very simple. And remember the intended nucleus, they have given the image in Robbins itself. I have taken this image from the Robbins where you can see these nucleus with which are having the cleavage, the centrocytes as you call it. So on a low power view you can see the definite follicular architecture, and a zoomed version will actually show you the cleaved nucleus as well. Okay, all right. And this is also important for the future aspirants to compare and contrast between CLL, mantle cell lymphoma, marginal zone lymphoma and follicular lymphoma. Often this or that question is being asked from it. Very important. Okay, all right. Okay, so the next question, elderly female with chest x-ray showing mediastinal mass was diagnosed with pure red cell aplasia. What is the most probable cause? Most probable cause. Now this is regarding the causes of pure red cell aplasia. Now among the acquired causes of pure red cell aplasia, the most common one is actually a thymoma. The most common one is going to be thymoma. And you can refer to the table in Harrison also regarding acquired pure red cell aplasia. But remember, when I say thymoma, even lymphoid malignancies also can cause. It can also be related to it, but the question specifically says the most common one. Okay, most probable cause, that is going to be thymic neoplasia. Okay, clear. Now next question, 20-year-old boy presented with fever of 1 month, gum bleeding and easy bruisability, petechial rashes on examination. Evaluation, there was pancytopenia. Okay, HB3, total count 1500, platelet count 15,000, peripheral smear showing macrocytes, bone marrow examination showed fatty streaks, absent megakaryocytes and no immature cells. So what is going to be the diagnosis? Now this is actually a simple one. Again, 20-year-old, fever is there, gum bleeds is there, EC bruisability is there, multiple petechial rashes and pancytopenia. Now peripheral smear is showing macrocytes. The bone marrow is showing fatty streaks. Now you tell me what is going to be the answer for this. Yes, see, at least some of you were answering, whether it could be myelodysplastic syndrome. Now what is the problem with MDS? The problem with MDS is that MDS usually will have a cellular marrow. But here, they have clearly told that the bone marrow is showing the fatty streaks. So the answer is going to be idiopathic aplastic anemia. I suppose the option was idiopathic acquired aplastic anemia. I suppose that was the option. So this is again, from Harrison itself, comparison of a normal bone marrow versus an aplastic anemia bone marrow. So you see it is fatty streaks and all the fat will be washed out and you can see vacuolations. Okay, so that is actually very, very clear. So this is a 20-year-old male with acquired aplastic anemia. Okay, all right. Next one, familial HNPCC is due to defected. What is going to be the answer? Familial HNPCC, what is going to be the answer? Again, a simple one, it is going to be mismatch repair. For the MBBS students watching, this again directly mentioned in Harrison. You see HNPCC is due to mismatch repair genes. So I'm in between, I'm just telling to the, conveying a message to the future aspirants as well, because, most of the questions is there in the standard textbook. So if you follow, say, any coaching platform, because all coaching platforms are having good classes, but along with that, if you follow your, your clinical postings sincerely and you learn from your standard textbooks and then, learn from us also, I think things are going to be very simple. I feel, even if you don't learn from us, if you are very sincere in your WOT postings and if you are, reading standard textbooks, that would definitely be enough. All right. Okay. So, 35-year-old female with claudication in forearm, transient loss of vision and abdominal pain. She had weak femoral pulses. Fundus showed retinal hemorrhages. Diagnosis. Now, first is look at the age. 35 years, it is a female. So, the 35-year-old female is having some forearm claudication, some transient visual loss. So, there is some vascular phenomenon happening. She is having a weak femoral pulse. So, this is not going to be atherosclerosis. Okay, this is not going to be atherosclerosis because it is a youngish female who is having diffuse vascular involvement. So, I don't think this is going to be atherosclerosis as the pathology. So, fundus is also showing retinal hemorrhages. So, there is weak femoral pulses. So, the most likely etiology is a vasculitis. Now, since there are weak femoral pulses and you see forearm claudication, so this is again pointing to large vessel involvement. So, I think this is a vasculitis and it is more likely to be a large vessel vasculitis. This is more likely to be a large vessel vasculitis. So, tell me out of these options given what is going to be the large vessel vasculitis, it is going to be Takayasu arthritis. So, somebody is recalling that the blood pressure also was low. Okay. So, fine, what the recall I got is this much. So, this table in Harrison again showing the different vessel involvement. See, subclavian is very commonly involved. You remember previously they used to give questions like, you remember the times when I prepared for the entrance exams, we used to have questions like, most common blood vessel involved in Takayasu arthritis is, answer is subclavian. It's not the, the arch of aorta, it's the subclavian. You can clearly see 93% is subclavian. But here what have they done? Instead of asking any such direct question, they have brought in the clinical features like arm claudication. Okay. So, and you see common carotid involvement can produce visual changes. So abdominal aortic involvement can produce abdominal pain. This is how the clinical scenarios are framed. So whenever you learn, not just medicine, even if it is your preclinical or paraclinical subjects, it is having a clinical perspective that matters. You've got to have a clinical perspective, okay? Which is why in the coming days also in DocTutorials, I'll be conducting some clinical case-based discussions of some clinical scenarios like this, so that it will be there in your mind for longer with actual case scenarios, okay? All right, so I hope this is again very clear, there is no doubt. And this is the ACR, American College of Rheumatology classification criteria for Takayasu. I'm not going into that in detail, okay? All right, and this is a very, very important table. Now, if anybody who is preparing for your exams, suppose, I know that there is no giant cell arteritis in the question, but if I ask you if giant cell arteritis was there, will you pick giant cell or will you pick Takayasu? Because you might say, sir, it is a large cell vasculitis, so both giant cell arteritis and Takayasu, both of them are large vessel vasculitis. But again, you see the age. This is regarding a 35-year-old female. So this is one table. This is again from Kelly's rheumatology textbook. So I have shown this in my lectures in DocTutorials app as well. So I'll share it in the PDF as well. The differences between giant cell arteritis and Takayasu. So you see Takayasu very common in females, but see the age range, less than 40 years, whereas giant cell arteritis almost always, the age group of presentation will be more than 50 years. Okay, all right. So, okay, so I hope that is clear. You can take a screenshot, or you can watch the go through the PDF that I'll be putting in my Telegram group. So once again, I'll just share my WhatsApp number and Telegram number 9447334944. Now, not just that, if you have not performed well in NEET PG also, if you need direction, I'll try to help you as a senior. Okay, I am not going to tell you some magic tricks, but again, whatever help that I can actually give you and whatever direction I can give you, I'll be happy to help. So when you text me, sometimes there may be a delay in answering because I get lots of messages in the inbox, but definitely I'll reply. Okay, in case I do not reply in a day or two, just send me one more reminder message. I'll definitely reply for that. Okay, all right. So, and let me tell all of you once again, if you have not done well in NEET PG also, I'll tell you it's okay. It's still okay. I'll just tell you one example. Maybe I'll take 2 minutes, just 2 minutes to just tell one example. So, one of my cousins, in fact, my wife's cousin, I'm not saying the name, but he's my wife's cousin, but he was once, while he was preparing, he actually gave the NEET exam, and they were actually a group of friends who actually studied together, and they wrote the exam. Except him, all of them got good rank in NEET PG. Okay, so got good rank in NEET PG. So he was definitely disappointed because he could not perform. So all his friends has got into NEET PG, very, very disappointed. So he was not talking to anyone for a few days, but again, I just had a word with him. So he told me, I'm a bit disappointed. I'm thinking of now working somewhere else and maybe taking a small break. So I told him this, see, you did not get a NEET PG, but again, that's okay. It is just one exam of your life and you could not perform well. What is a big deal? Failures happen to everyone, no? So I know that is a cliche dialogue, but that is a fact. Even if you fail once, that is okay. Please remember, it's okay to fail. It's okay to get, low marks in the exam. Only thing is that you should bounce back. Okay. So at my compulsion, he started attending classes again. He prepared again. The very next aims that came in, because this actually happened 3 years back, but that time it was not INICT, it was aims. He got into aims. And he got ophthalmology in aims. So now, a couple of months before, he has completed his MS Ophthalm also from aims. I just want to give you one message, that there was one point of time where he was desperate. He felt, he did not get, the others all got through. So there was a dejection phase. At least some of you would be having this, at least some of you. I just want to spare a couple of minutes for you. So this dejection is a temporary phase, just like you take a camera photo. At this moment of time you are dejected, you might feel you have failed, but with a smile just accept the failure, but you just see what is up next. If you want to target the next INICT, rather than keeping lamenting over your failure, please go ahead and learn for the next exam. Okay, so you have INICT coming up. I just want you all to work hard. Okay, all right. So I hope at least that message is conveyed to a few of you. So again, any doubt, just text me in my WhatsApp or Telegram. So male patient presented with feeble pulses and upper limb BP of 185/90. Chest X-ray shows inferior rib notching. This is what I could, this is what I could actually get. So anyone can further recollect? So the answer to this is actually coarctation of aorta. There is no doubt in that, but I just wanted to see if you could recollect the rest of the part of the question. Okay. All right. So the answer to this is coarctation of aorta. Again, very simple. Again, it is affecting the aorta, and there is a narrowing, and there is a lower limb pulses are very much feeble. And I am sure that the radiological finding of inferior rib notching would have sealed the diagnosis. Coarctation of aorta. Okay. So the previous one is Takayasu. I think somebody was asking Takayasu, and this one, the answer is coarctation of aorta. Now remember, while I am discussing, if there is any question that I have missed out, just let me know in my Telegram group, because we are just one day after the exam, so maybe here and there I might miss a few questions. Just let me know in the Telegram group. I'll answer to that. Meanwhile, I'll share this also in the group. So this is again inferior rib notching in case of coarctation of aorta. Okay. All right. So next question is a patient presented with seizure, urine osmolality of 1000, serum osmolality of 270. Further evaluation, what electrolyte abnormality are you expecting? This one again a simple question. See, patient is having seizure, but you see there is a high urine osmolality and a low serum osmolality. Now in this combination, patient with seizures, low serum osmolality, high urine osmolality, what are you thinking of? My first thought process is to syndrome of inappropriate ADH secretion, SIAD. Okay. Most of the exams, there will be one question related to either SIAD or cerebral salt wasting or diabetes insipidus. Okay. So this one is going to be SIAD. So what is going to be the electrolyte abnormality? Hyponatremia. Okay. Now this again, if you want, you can take a screenshot of the comparison between SIAD, cerebral salt wasting, and central diabetes insipidus, because I know some students have confusion in this. Okay. So just learn this. All right. Okay. Fine. Now the next is a simple one. A patient complains of urine blackening on exposure to air. What is the enzyme defect? Well, this is again a simple one. So the answer is going to be homogentisic acid dehydrogenase. Another name is homogentisic acid oxidase. In the option it was dehydrogenase, means the same. And the other enzymes also of this tyrosine pathway actually was mentioned. And do you know, Harrison also mentions the same. I know this is a simple question, but still, which is you are learning in biochemistry. But see, all the options, this is regarding the inherited disorders of amino acid metabolism in Harrison. So all the other options were actually picked up from the enzyme defects, involving tyrosine. Okay, if you see, all the other options were picked up from that. Okay, the other options. Okay, homogentisic acid oxidase, also known as homogentisic acid dehydrogenase. Okay, all right. Now a patient stopped alcohol for 3 days and presented with irritability and disorientation, paranoid delusion, visual hallucinations, and altered sensorium. Most likely diagnosis. Now tell me, what is the most likely diagnosis here? Now there are two important points. Now first is it is an alcohol related symptom. There is no doubt regarding that. Second is the timing. It has developed, he stopped alcohol for 3 days. And then he is developing disorientation, paranoid delusions, visual hallucinations, and altered sensorium. So this is the classical presentation of delirium tremens. This is the classical presentation of delirium tremens. Now you see, One of you is actually commenting on alcohol withdrawal seizures. Now you see the timing of alcohol withdrawal syndromes, this is actually important. Now for a delirium tremens, the classical time period is 48 to 96 hours. Whereas you can have minor withdrawal symptoms in 6 to 36 hours. Okay, you can have seizures in the 6 to 48 hours interval, because at least some of you would have encountered cases where you have had a shorter duration and patient presenting with seizures. And alcoholic hallucinosis also in the 12 to 48 hours period. Okay, all right. So that is going to be delirium tremens. So this is just again to show the delirium tremens symptoms. I am not going into the detail. I will be sharing the PDF with you in the group. Okay, all right. Now patient is diagnosed of multiple sclerosis. The disease mainly affects. Now this is important. Multiple sclerosis is a disorder that predominantly affects the oligodendrocytes. This is a disorder that affects the oligodendrocytes. Now when I say oligodendrocytes, let me just try to explain to you. See, what is actually happening in multiple sclerosis? Brain is usually an immune privileged site. So normally the immune cells are not attacking your myelin sheath, because if it was attacking for even a minor respiratory infection of yours, the inflammatory cells would have leaked and reached the brain interstitium and attacked the neuronal cells. But what happens is that in multiple sclerosis, from the intravascular compartment, first of all, there is an increased permeability. So there is an increase in the permeability and the inflammatory cells. I'm not going too much into the detail. In the main section of the DocTutorials app, I have explained how multiple sclerosis occurs in detail, the pathology. But again, inflammatory cells are actually coming out, and these inflammatory cells, what they do is that they will go and destroy the myelin. I'll just show you one figure. This is again the same figure I have shown in the lectures also. You see, this is the peripheral lymphoid tissue and this is the central nervous system. Remember, in multiple sclerosis you have the B cells as well as the T cells. So from the periphery they gain access, the intravascular compartment, there is increased permeability, they gain access to the brain interstitium, and then whom are they going to attack? You see, oligodendrocyte. Previously it was thought that these the inflammatory cells are going to attack, the T cells are only the ones that are important, but here the B cells are also going to attack the oligodendrocytes. So the predominant damage is to the oligodendrocyte. Okay, but in the final stages I agree that there is neuronal damage, astrocyte injury, but the main site of injury is oligodendrocyte. Okay, all right. So I hope that is again clear. The answer is B lymphocyte. The answer is going to be the oligodendrocyte. Now next is a patient presented with headache for 6 months. She took analgesic regularly. The headache has been increasing and became severe for the past 3 days, but reduced on discontinuing analgesic. Likely diagnosis. Just tell me what is going to be the diagnosis. So some patient is having a chronic headache, and the headache, for the headache he was taking the analgesic regularly. Okay, was taking the analgesic regularly, and the headache intensity has become severe for the past 3 days. But the moment on stopping the analgesic, usually the analgesic gave pain relief, but now on stopping the analgesic, what happened is that the pain there was a pain relief. Okay, so what is going to be the answer? The answer is going to be A, medication overuse headache. Okay, which is often abbreviated as MOH. I'll tell you what MOH is in 1 minute. See, many patients who come with headache to the medicine department or neurology department, somebody might put the patient on long-term NSAIDs or triptans. Remember, these are drugs for aborting an acute attack. So some might not know this. Okay, this is for acute attack and certain drugs for prophylaxis. So certain individuals, they keep the patient long on these NSAIDs and triptans and all. So certain analgesics, okay, like this NSAIDs, triptans, opioids, on long-term intake, they can actually lead on to headache. Okay, so the headache because of the analgesics, that is an analgesic induced headache or a medication overuse headache. Okay, so the commonly implicated ones in medication overuse headache is going to be analgesics, opioids, butabitol containing products, ergotamine, triptans alone or in combination. Okay. Now, why does this occur? Excessive medications producing headache. Well, it is because of the facilitation of the central trigeminal system, and there is a, what happens is that, there is a, I have taught you in detail the pathogenesis of migraine. If you have listened to my lectures, I have taught you how migraine occurs conceptually. I am sure that if you have watched that lecture once, you will definitely understand how actually migraine occurs. Okay, the trigger of migraine, the cortical spreading depolarization, the ascending spread from the brainstem, the descending pathways. So the descending modulation is also there. So there is some sort of an induced impairment of the descending inhibition of the nociceptive trafficking, which is why you get a medication overuse headache. Okay, and I have specifically mentioned this entity. In fact, in the lecture on migraine, I have mentioned regarding overuse of triptans and or leading to medication overuse headache. So the answer is MOH. Now for the MBBS students, sir, what an entity, MOH, I have not heard. Dear student, this is there in your Harrison. I have just highlighted the part from Harrison, medication overuse headache. Okay, overuse of analgesic medication for headache can aggravate headache. That is called a medication overuse headache. I hope that is clear. Now, while performing a lumbar puncture, which of the following layers is punctured last? Now, this again in my lecture on acute bacterial meningitis, I have shown you a picture and also I have written it down on the layers that are actually punctured in case when you are performing a lumbar puncture. So, in order, see, this is again a basic question. I won't say this is again, this is not an anesthesia question, this is a basic medicine question. Because if you are in the wards, if you are sincere in the wards, you would have definitely seen the lumbar puncture being performed and you should know what are the layers being, definitely I'll be sharing the telegram, Alia, I will be sharing this entire PDF in the telegram group, don't worry regarding that. So skin, subcutaneous tissue, so first skin will be punctured, then subcutaneous tissue, then the supraspinous ligament, interspinous ligament, ligamentum flavum, epidural space, dura, arachnoid and subarachnoid space. Okay, so in this question, what is going to be the answer? Arachnoid. Okay, arachnoid is going to be the answer. Okay, all right. Now, what is going to be the answer for this? Person on a construction site fainted. Skin turgor is decreased. Temperature was 105 degree Fahrenheit. Which is the least likely, which of the following is least likely seen? I am just waiting for your answer. Just type in the answer. Meanwhile, let me just check my camera status, video, let me just check 1 second. Okay. So just let me know if I am audible. Just let me know if I am audible. So see, this is regarding a patient on a construction site. Okay, so he has fainted, so skin turgor is decreased, there is high temperature. So first of all, what is the likely clinical diagnosis? The likely clinical diagnosis is that of a heat stroke. The likely clinical diagnosis is that of a heat stroke. Now I can see some of them typing D, sweating. Many of them are typing sweating. Some are typing tachypnea. Some are saying hypotension was the option. So first of all, let me know if the option everything is correct. So the answer to this question, okay, the answer to this question, can you tell me? Yeah, this is going to be bradycardia is going to be the answer. So bradycardia is least likely to be seen. Now I'll just show you. Okay. Now this again for the MBBS students, this is again a question which can be easily answered if you have read Harrison. Okay. Okay. So the thing is, in case of heat stroke, there are two types of heat stroke. I'll just simplify it in 2 minutes. There are two types of heat stroke. One is a classical variety and the other is a exertional variety. See, the classical variety is the one that is seen in older individuals when you are being exposed to your summer waves. Okay, older individuals with comorbidities exposed to, summer waves, that is when you develop the classical variety. The exertional one is the one that occurs in laborers, athletes, okay, comparatively younger patients, healthy cases. So while you are exercising. So the other one, the classical one, occurs when you are sedentary, but there is plenty of heat waves. Now, so this is actually an exertional type of a heat stroke. That is number one, exertional type of a heat stroke. Now you see here, the athletes, laborers and military recruits are the individuals affected by a exertional heat stroke, EHS. Okay. Now this is very, very important. Unlike the classic variety, the patients with exertional heat stroke are profusely diaphoretic. So sweating is definitely there in an exertional variety. The question definitely says exertional variety, so there is definitely sweating is a feature. Okay, sweating is a feature. So you can see along with that other tachycardias are there. You can have hypotension, widened pulse pressure. These are the other features. Okay, so bradycardia is not a feature. Okay, I hope bradycardia was there in the option, no? All right. So bradycardia is not in the option. Anyway, so just let me know if the recall is right. So Shashank is saying, you are having a doubt regarding sweating and heat stroke. Listen, I told you there are two varieties of heat stroke. In the classic variety, there is no sweating. But you can clearly see this line from Harrison. In the exertional variety, that is the one that is seen in manual laborers, when you are exerting, in that, you will definitely have sweating. Okay. All right. So I hope that is again clear. Now next question is regarding patient with history of recurrent retrosternal chest pain, each episode lasting for 3 to 5 minutes and subsiding with sublingual nitrate. Patient presented with in the emergency with chest pain. Now, so he has been having features of chest pain. So probably it was a stable angina, chronic stable angina, because there were no other symptoms and on taking the nitrates it was getting resolved. But now he is having some new onset worsening of this chest pain, and he is a known case of diabetes, hypertension, hypercholesterolemia, and he is on various drugs like statins, aspirin, atenolol, metformin. ECG shows LVH with flat T waves. What is the next step in the management? Okay, so just let me know what is going to be the answer here. What is going to be the answer here? Well, first of all, remember in this exam question paper we have seen there are lots of questions based on management. So first of all, in most of the question it requires you to make a clinical diagnosis first. So the clinical diagnosis that I would make in this case is that of a unstable angina. Unstable angina. But remember that management wise, whether it is unstable angina or a non-ST elevation myocardial infarction, both is actually same. Okay. Now can you tell me, as per the latest guidelines, okay, the unstable angina and the non-ST elevation myocardial infarction, can you tell me they are together grouped into, with respect to management, they are together grouped into one entity. Can you tell me what is that name? The name is non-ST elevation acute coronary syndromes, because both of them are managed in the same way, which is why they are called non-ST elevation acute coronary syndromes. Okay, all right. Okay, so that is very, very clear. Now, regarding the management of this patient, I can see many of them going for injection heparin, some saying clopidogrel, some saying even GTN infusion. So, see, I'll tell you, first of all, if I ask you regarding the management of non-ST elevation acute coronary syndrome, now this is a very common entity, right? If I ask you, what is the management guideline? You must quote a guideline. What guideline are you going to quote? Because often I have seen students, when they learn regarding management of myocardial infarction, they might just casually learn the management without knowing what they are quoting. See, in the current medical practice, we are all going for evidence-based medicine. So whenever you manage such common and very important life-threatening conditions, you should know which guideline you are quoting. So for your unstable angina or non-ST elevation myocardial infarction, you should either be quoting the 2014 guidelines of the ACC-AHA, which is the American College of Cardiology, American Heart Association, or the one I would prefer is the latest one, that is the 2020 European Society of Cardiology guidelines for patients without ST elevation, acute coronary syndrome in patients without ST elevation, which is your non-ST elevation acute coronary syndrome. Now I'll tell you something. In case of cardiology myocardial infarction, there are two important bodies. One is the ACC-AHA and another is the European Society of Cardiology. I am sure the first question you will ask me is, sir, out of these which you should learn? Both of these are standard authorities, whether it be ACC-AHA or ESC. However, it is always better to quote a guideline that came in 2020 than to quote a guideline in 2014. Which is why in my lectures also, I have never taught you like, okay, management, you give this drug, this drug. If you watch my cardiology lectures, I have specifically told you what drug and when to give, okay? Because it has to be in a guideline oriented manner so that you know, okay, which drug to give first, what dose you should give. You're supposed to know that, okay? Now, even if you take the table in Harrison, which I have just put as the screenshot, so the initial treatment and of the patients. So whenever a patient is coming with say an acute, so Alia, I think you are having a doubt in the previous question. I'll just come back to that. Okay, don't worry. Just wait. Okay, I'll come back to that. So for this patient with a non-ST elevation acute coronary syndrome in the emergency, see, definitely you should give the patient antiplatelet, because is there a need for GTN infusion? They have not told, like the chest pain, they gave sorbitrate this time and it was not subsiding. They have not told anything like that. So GTN infusion less likely. Increase the dose of beta blocker. See, beta blocker is forming a part of the management, but it is not very important in the acute stage. It is not playing a crucial role in the acute stage. Now, both of these are actually given in the acute stage, that is the low molecular weight heparin as well as clopidogrel. But you see here, out of these two options, what is going to be the most important step? Is this going to be clopidogrel, addition of a clopidogrel, or is it going to be injection of low molecular weight heparin? The answer is going to be injection low molecular weight heparin. I have taught you in detail regarding how to manage NST-ACS in my lectures, okay, so you can go through that. Meanwhile, let me come to Alia, your doubt. Laborer presented with the following options. So you say that one option was red hot skin, yes, so that was there in the option. So sweating, tachypnea is there in the option, and you are saying hypotension is also there. Am I right? Can somebody just tell me, is it right or not? But whatever it is, Alia, the answer is going to be, least likely to be seen. You're right. You're saying least likely to be seen. Is that one? Can somebody tell me whether the recall is right, the recall for the question on heat stroke? Red hot skin, tachypnea, bradycardia, sweating. Okay, so you are saying that there was no bradycardia, correct? All right, see, in this case, you see here, now the question is you have got to choose. Anyway, you will have to, red hot skin is definitely there. Now it is regarding choosing between either tachypnea or sweating. Now if you see here, hypotension is definitely a feature. If you see the exertional variety of heat stroke, you see here the diaphoresis they have mentioned as a common symptom. You have see the Harrison specifically says diaphoresis is common. Now the only thing I want to know from you is that wasn't the history that of somebody who was a laborer who was working and then developing a heat stroke, correct? If that was the question, this is going to be a exertional variety. It's not going to be a classic variety, because classic variety, you see, this is regarding heat waves, somebody who is older exposed to heat waves, but otherwise exertional. I would also agree the classic variety sweating is rare, but Harrison specifically says diaphoresis is a common symptom. So I think you might have to go for tachypnea here as a manifestation. Otherwise, okay, you will have to go for tachypnea here because diaphoresis is being mentioned as a common variety. However, if there is a difference in recollection of this question and if it turns to the classic variety, just let me know if it was the classic variety, if there was some recall in the history part, then only I'll go to the other side and I'll definitely tell you sweating is very rare. But if it was exertional, remember diaphoresis is a common symptom, then you might have to go for tachypnea as the least common feature. Okay, all right, fine. So I hope that is clear. Okay, yes, okay. So anyway, remember this is actually because even when I say this, there is a bit of doubt because I also do not know whether exactly the exertional was asked. Because if you ask me whether tachypnea is a feature of the exertional variety, it is definitely a feature because I have already showed you that the patient can have tachypnea, tachycardias, hypotension, wide pulse pressure. But the only thing is that whether it is exertional or not. So that is a bit of controversy there. Okay, all right. So if it is construction worker, then God knows, everything looks to be, fitting. So that's the only thing. Was it mentioned anything regarding old man or young person? At least if that could help. Was anything mentioned regarding that? Anything mentioned regarding that? Can somebody recollect? All right. So let's make a consensus here like this. If the question definitely meant an exertional, the answer can never be diaphoresis because they say it as a common symptom. But tachypnea again can occur, but you might have just to take that. Okay. So anyway, it depends on the recall. Okay. It's again a tough question, I would say, in case the question is just like what you are saying. Okay. All right. So the next question, patient presented with fever, nocturnal cough, breathlessness and wheezing for 4 weeks. The absolute eosinophil count is more than 5,000. The X-ray shows the miliary pattern. It's not a military pattern, it's a miliary pattern. Okay, a miliary pattern. What is going to be the diagnosis? Now you tell me what is going to be the diagnosis. The diagnosis here, the patient is having fever, nocturnal cough, breathlessness. Total illness duration is 4 weeks. So let me ask you first of all, can this be tuberculosis? Can this be tuberculosis? Miliary tuberculosis? Well, the problem with miliary tuberculosis is, yes, it can have cough, breathlessness, even wheezing also. but absolute eosinophil count more than 5000 is not favoring tuberculosis. Now if I say bronchial asthma can have an increased eosinophil count, but again bronchial asthma is not going to have a miliary pattern in the X-ray. So what is going to be the answer here? It is going to be tropical pulmonary eosinophilia. Okay, tropical pulmonary eosinophilia. Okay, so again for the MBBS students, tropical pulmonary eosinophilia has been mentioned in Harrison. Regarding the clinical features, the eosinophilia often more than 3000, okay, and diffuse miliary lesions are seen in the lung fields, okay, especially in the middle and lower lung fields. Now a few simple questions, okay. So Akash is saying in the last question, that is in ACS, troponin was negative. Akash, remember, troponin negative means it is unstable angina. Troponin positive will take it to be a non-ST elevation MI, but both of them are grouped under a non-ST elevation acute coronary syndrome. So the management is going to be the same. Okay. Alright. So the answer is quite clear for that. Mechanism of action of methotrexate, again it is inhibition of dihydrofolate reductase. Mechanism of action of tocilizumab is interleukin 6 receptor antagonist, again a very simple one. Okay. So Harshita, your question is, if in the question the patient is stable, she is talking of the question on the unstable angina. If the patient is stable and troponin is negative, clopidogrel more than enoxaparin in emergency. No Harshita, it is definitely going to be enoxaparin or low molecular weight heparin, because unstable angina as well as NSTEMI, non-ST elevation acute myocardial infarction, both are managed the same. And for both of them, the most important intervention is actually going to be low molecular weight heparin. Okay, there is no doubt on it. Okay, all right. Now, next is regarding a question, patient with end-stage renal disease and peripheral edema, which antihypertensive is safe? Let me know what is going to be the answer. End-stage renal disease patient and there is peripheral edema, which is the safe antihypertensive? Let me know. What is the safe antihypertensive here? What is the safe antihypertensive? I can see some saying A, some saying C, D. See, definitely this is going to be a patient with end-stage renal disease, correct? End-stage renal disease. So in patients with end-stage renal disease, see, how can you say that, most of the drugs, if you give a patient with beta blocker at that time, which is reducing negative inotropic action also, in such a case, it would actually lead on to further fluid overload. So I think, in this, the best option is actually to go for chlorthalidone. Okay. The best option is to go for chlorthalidone. Okay. Since this is a patient with the end-stage renal disease, among the options, you can go for chlorthalidone. Okay. If there is any difference in the recall, please just let me know in my Telegram group. Okay. In any of the question that I actually put. Hypertensive female becomes pregnant, which drug has to be changed? Okay. Which drug has to be changed? Tell me. Which drug has to be changed? Hypertensive female becoming pregnant. Which drug will you have to change? Which drug? So was there anything mentioned about hypertensive female becoming pregnant? Yeah, so the answer is going to be which one? Yes, AAC inhibitors. So AAC inhibitors should not be given. Okay, so in patients who are actually pregnant, so you'll definitely have to change it. Now, young boy with difficulty in vision, especially during night, examination showing the following finding. What is going to be the diagnosis? Tell me what is going to be the diagnosis. The diagnosis is going to be phrinoderma. So you can see this keratotic lesions. Okay, the keratotic lesions. This is actually phrinoderma, vitamin A deficiency. Okay, phrinoderma of vitamin A deficiency. Now, two questions were asked with respect to pellagra. So the question is, in a patient on maize diet with diarrhea, dermatitis and dementia, which is the vitamin that is deficient? So the answer is going to be vitamin B3. Okay, vitamin B3. Now in patients with skin changes, what history will you ask for? So this patient was having the following skin changes, which was suggestive of a Casals necklace. Okay. Okay. So you will ask for history of diarrhea, dermatitis and dementia. So the answer is going to be diarrhea and memory problems. So next is metronidazole should not be used with. What is going to be the answer? Metronidazole should not be used with. Answer is going to be alcohol. So why is it going to be alcohol? There is always a fear of disulfiram reaction. Okay, there is always a fear of disulfiram reaction. Okay, disulfiram reaction. Okay, all right. So that's it on the question recalls. If there are, let me tell you, this is just based on recalls that I have got from students. So some of the recalls may be partially correct with respect to the options. So if there are certain other questions also, because these are the questions which I could manage. If there are certain other questions also, just inbox me either personally or in my Telegram group. I'm just sharing my number again. So 9447334944. So just, if you have any other queries also, please text me. Okay. All right. So just text me in my number either in WhatsApp or Telegram if you have, any doubts regarding that. And also if you feel some questions require any clarification or additions also. So all right. So thank you everyone for joining in, and any other question, just let me know in my Telegram group. I'll be happy to discuss those questions. Okay. So there is some question on CSF shunt, somebody is saying. So whatever doubts you have, please keep posting in the Telegram group. So just, you can inbox me. I'll just send you the link of the Telegram group. Okay. All right. So some circumflex iliac artery blockade question. So I have not got the recall for that question. So please actually send me that question. Okay. So Tawheed is saying that one question was amlodipine. So can you again just send me in Telegram? So Vishal, in my Telegram group, I'll be discussing the question. So if you have any doubts, you can just send me a WhatsApp or Telegram. You can inbox me in Telegram. I'll be happy to, share the link of my group. Okay. All right. So thank you everyone for joining in. Okay. All right. Okay. Okay. So all right. Thank you everyone. Bye-bye. Okay. So take care everyone. Take care.